Welcome to AETCM, the emergency medicine channel. Today we'll be discussing a case of a young female who presented to us on her post-op day 5 following a laparotomy with complaints of breathing difficulty. Can we begin, sir? So there was this 26-year-old female patient who she recently underwent emergency laparotomy. Details we'll figure out later. She was pregnant, then she dealt with a life-threatening complication, then she underwent emergency laparotomy for the same, and now she presented to us with worsening breathing difficulty. So in our initial 10-second assessment, patient was conscious and oriented, obeying to our commands. Primary survey-wise, airway appeared patent with no increased secretions, no change in voice, there was no anatomical deformity, no pooling of saliva noted. Breathing wise, she was tachypneic with a respiratory rate of 31 cycles per minute, with a saturation of only about 84% on room air, and she appeared to be with usage of little accessory muscles. Increased work of breathing was also noted. Then, but auscultation wise, air entry was bilaterally equal, with chest being clear in the upper zones of the lung fields, whereas the lower zone there was decreased breath sounds. Circulation wise, she had a heart rate of 84 beats per minute with blood pressure of 126/70. All peripheral pulses were palpable and the rhythm was regular in nature. Then disability wise, she had a full GCS score of E4 V5 M6 totaling up to 15/15 with pupils being 2.5 mm bilaterally reactive to light. Exposure wise, she had a normal body temperature and had a blood sugar levels of 124 milligram per deciliter. So at this point, we noticed that the patient was having an issue with the breathing parameters. So we initiated the patient initially on nasal prongs. With that, her saturation picked up till 98%. And work of breathing, she's little tachypneic, but that settled in due course of time. Now, ABG wise, she had respiratory alkalosis with a pH of 7.54 with a PCO2 of 38, and bicarbonate was 32.9 with a PO2 of 52.6 and a saturation of 88.8. So hypoxia was also seen, but the lactate levels were only 1.1. So apart from that, we took an ECG which showed
sinus. What is the ABG?
Respiratory alkalosis and type 1 respiratory failure, hypoxemia. So then ECG just showed sinus rhythm. There was no acute STT changes. And ultrasound, these were just the adjuncts to primary survey. Now talking about the secondary survey. In secondary survey, we find out that this patient was pregnant for the 4th time, which was her precious pregnancy. The first time in the year 2018, she conceived via ovulation induction, but she unfortunately had a spontaneous abortion. When she conceived for the second time, turned out that it was an ectopic pregnancy, and she underwent laparoscopic salpingectomy in 2020. Then she conceived for the 3rd time, which again was a missed abortion. So this was a precious pregnancy. LMP was on 17th of May and she was supposed to deliver on 26th of February. But on 30th, she suddenly had acute onset of abdominal pain with generalized discomfort, insidious onset and worsening breathing difficulty. So when she went to a local hospital, there they evaluated her, found her to have a placental rupture, and along with this a uterine rupture basically. So she underwent an emergency laparotomy on 30th of November. So this was her second trimester. She was on her 6th month of gestational period. Details of that was not really known. It was documented that the baby born was deeply asphyxiated with ambiguous genitalia and low birth weight. So baby did not survive. It succumbed. And also she was transfused 5 units of blood, and in view of pulmonary embolism as one of their DD, they did a CTPA, pulmonary angiogram, wherein it ruled out pulmonary embolism, but it showed left-sided bilateral collapse, but left-sided had a collapse consolidation with atelectatic changes. So with this in the background, she was referred to us for further management. So as our other adjuncts, we also did an X-ray which confirmed minimal effusion bilaterally with collapse consolidation on the lower zones of the left lung. Apart from this, the lab investigation wise, she was found to have infection with the CRP level of 101.6 with a total counts of 15,700. She was not anemic. Hemoglobin was 12.4, but then again she had a background of 5 units of blood being transfused. Then her other parameters were fine, but she also had hypokalemia corresponding to the metabolic alkalosis. Potassium was found to be 2.9. Possibly in the other hospital, they could have given her diuretics. With this history, our examination, other systems were fine. Respiratory systems just confirmed the findings of the primary survey, wherein she had reduced breath sounds in the lower zone with increased work of breathing. Cardiovascular and neurological systems were unremarkable. Per abdomen, her uterus was relaxed and wound appeared healthy. Cervix, there was no active bleeding PV at present, and os was closed. So this was her gynecological and clinical examination. So with this in mind, our DTs was one, an LRTI that could have led, that collapse consolidation could have been because of that, or because when she was taken for an emergency laparotomy at that point in time, that surgery was done under GA. So considering second trimester, a full abdomen pregnant patient, she could have aspirated, which could have again led to an infection, or that could also lead to collapse of the left lung. So when we discuss about intubation in pregnancy, the very fact that a patient is...
Continue your DDs.
So then the other DD could have been an amniotic fluid embolism.
Bilateral.
It could have obstructed and...
Unlikely to have bilateral changes, right?
Yeah.
What else?
Then pulmonary embolism, amniotic fluid, or pregnancy itself is a high dynamic, hyperdynamic state. So cardiac failure could have led to second trimester because of the stress. There can be a stress cardiomyopathy, cardiac failure, or ARDS.
So when this patient is referred to us, already the primary investigations has been completed. Since primary investigation is completed and it's written that patient is having bilateral lower lobe collapse consolidation with minimal effusion, we are biased towards LRTA and parenchymal disorders of the respiratory system. But if we take that thing out, then this is a post-op patient presenting with acute breathing difficulty with multiple DDs present. So it's better to present in such a way, because right now it is highly biased towards LRTA. We know, because it's a CT proven case and totocounts are elevated, CRP is elevated. It's a no-brainer. So let's take the CT out, discuss the case. Like, this is a pregnant woman presenting to emergency department with acute abdominal pain. That's how she presented to outside hospital, right? Acute abdominal pain with breathing difficulty. Let's discuss the case like that. So, same patient presented to your hospital, gestational age, having the acute abdominal pain associated with the breathing difficulty, generalized tiredness. How will you go about?
At that point in time, we'll have to ask her if she's got any bleeding PV, because that would be an important history. If at all she has bleeding PV, then, and considering her past history of abortions, this could have also been a spontaneous abortion.
That's true, but at that time we are doing the guesswork. Let's not go like that. We go like any other patient. This patient is presenting to you, first and foremost, is airway, right? Airway. 10-second assessment, go for airway. Airway is clean, then go to breathing difficulty. She complains of breathing difficulty. What you will check? You will check respiratory rate, you will check air entry. Let's put same findings. Bilaterally, air entry is there in the upper zones, lower zones. Patient is having decreased air entry with crepitations. Okay, patient is having a desaturation of 80 to 85% on room air. Use of accessory muscles present. Go. What do you do?
So in this case, patient has desaturation, so we can place the patient on nasal prongs. But if the patient has increased work of breathing and is obvious, like has respiratory distress, in that case, we'll think of a non-invasive ventilation or a high flow nasal cannula can also do.
Okay, so right now patient is in hypoxia. We don't know what is the, whether it's type 1, whether there is an underlying type 2 or any lung parenchymal disease is there. We just know that decreased air entry with crepitations on the lower part of lung, which is unusual for a pregnant lady, isn't it? Okay, what are the respiratory changes in a pregnant lady?
They'll have increased tidal volume, then
They will have increased tidal volume.
decreased tidal volume
Yeah,
with
they have
increased
a much
respiratory
more
rate.
full abdomen, right? Our uterus is pushing up, so diaphragmatic movements is going to be hindered.
Hindered. So
Yeah.
increased respiratory rate will be there, decreased tidal volume, total lung capacity will also decrease, and then
Function.
functional
Functional residual capacity is going to be decreased.
decreased.
Let's keep this in mind. Right now, first of all, as you told, we will put the patient on oxygen. Now, your second thing is, since patient is having respiratory distress, we may have to think about positive pressure ventilation. If we are thinking about positive pressure ventilation, what is the challenge you are going to face?
She's a full abdomen patient, sir.
Yes. So patient being full abdomen,
Aero feature.
there is a anatomical complication that is preventing lung expansion. Okay, so you giving high pressures of positive pressure ventilation in this patient will lead to,
Hypotension and again barotrauma.
it can lead to barotrauma and hypotension due to raised intrathoracic pressure, but that will be a bit later on. But barotrauma is a possibility here, and more than that, patient will become more agitated because you are pushing in a positive pressure into this patient. Now, that is one thing. So, let's not put positive pressure right now. Patient is having acute distress. Let's see after starting oxygen how much of relief she will get. Okay. So, in primary survey, start oxygen. Same time you can ask for ABG. You don't have to wait for primary adjuvants of primary survey to ask for something. Whatever you see, manage it, ask for investigation, then move on. So, ABG and oxygen, you start. Fine. What else? You're coming to circulation. Think that this patient's BP is 90/60. Peripheries are cold, rapid thready pulse, heart rate is around 138. What do you want to check?
So the first thing we'll do is to push the uterus to the one side.
Good.
Relieve the
What side?
Left side.
Left side.
Left side. Left lateral
Just
push will give. Otherwise, we can give a slight tilt to the left lateral side by keeping a wedge on the right end.
correct.
That is to relieve the IVC, inferior vena cava, supine hypotension syndrome can happen. So
Yes,
they'll
fine.
get the more preload.
Okay.
So then, apart from that, we'll see if the patient has any active bleeding that could have led to hypotension.
Yes. The most obvious source of bleeding is going to be
Bleeding PV.
bleeding PV. That's the easiest thing you can check for is bleeding PV. Similarly, you can ask about any sporting history to the patient. Then, what else will you look for?
Heart failure features. Acute pulmonary edema, heart failure features again because second trimester patient will have increased blood circulation.
Yes, the total blood volume of the patient is significantly raised by second trimester. And the end of third trimester, you will get significant dilution, hemodilution causing rise in blood volume.
So hyperdynamic circulation causing circulatory failure.
Okay, and not only that, we told heart rate is around 122, rapid thready pulse. What are the changes you expect in pregnancy in cardiovascular?
Increased heart rate.
Increased heart rate because
Stroke, cardiac output
has to be elevated due to increased demand. Since increased demand is there, heart rate will be automatically elevated. What about blood pressure?
Blood pressure, systolic blood pressure increases. The pulse pressure will become high. The pulse pressure.
Pulse pressure becomes high due to
diastolic drop.
Diastolic blood pressure decreases. Usually in the end of first trimester, diastolic pressure start decreasing, and by the end of the second trimester, diastolic pressure becomes stable. But pulse pressure widening will be happening. Okay, so this patient is having 90/60 BP with a heart rate of 122. Do you think that is normal?
No.
That's very unlikely to have a 90/60 BP for
BP.
a pregnant lady, isn't it? So we need to think about a ongoing circulatory collapse. Even if the BP is on the normal side, we need to think about a circulatory collapse with a hypoperfusion. And you have to think about cardiogenic shock. Cardiac failure or cardiogenic shock you need to think about. So,
Prothrombotic state.
yes, prothrombotic state.
So pulmonary embolism.
Pulmonary embolism we can think about in this patient. Acute breathing difficulty is there, pregnant patient. Pulmonary embolism is there. We'll come to those definitive diagnosis later. Right now we are just seeing the patient, right? Let's come to definitive diagnosis later. We don't have history or anything. Now, as you told, you look for features of cardiac failure. What are the features of cardiac failure?
One depends on whether it's with reduced fraction or with preserved fraction, but here it will be with reduced fraction. So it will be patient will have bilateral pedal edema can be
But
there.
it's a pregnant lady.
It will be there. Then
Is there any clinical sign that can show you patient is having cardiac failure?
Murmur, again pregnant female galloping.
So unless you get a S3 gallop rhythm, you can't say a pregnant lady having cardiac failure clinically. It's not like you can't, it's pretty difficult because patient will have pedal edema, patient will have elevated JVP. If at all, if it is possible to look, it can be due to the compression of, return of venous compression also can elevate the JVP. Patient will be breathless. That LV failure can be looked into because bilateral crepitations, inspiratory crepitations are there. You can say LV failure is there, but RV failure features will be hard to detect. Ideally, if you are suspecting cardiac failure on a pregnant lady, it's better to go for a bedside echo. Okay, then what?
As the DD, sir.
No, cardiac part we have done. Then heart rate is elevated. What is the other logical reason for this heart rate elevation for this patient?
Can you go for a USG fast without any free fluid in that?
Yes, we can because patient also complains of abdominal pain. So this patient presenting with acute abdominal pain, a trauma history is very much possible. Pregnant females can develop trauma because of lower center of gravity being pushed up, they tend to fall. So fall history, you can do a E-fast to rule out any bleeding.
Then other causes of surgical causes for abdominal pain like
that has to be evaluated.
Appendicitis.
Yes. So abdominal examination has to be done, but comes in secondary survey. Let's go there. Now respiration, cardiac is done, circulation is done. Then disability. Disability as such is normal. Fine. Now coming to primary survey adjoints. What and all you want to do?
One ABG to look for any PCO2 build up.
Yes.
Or any hypoxemia features.
So in ABG you are getting respiratory alkalosis with metabolic alkalosis, right? What was ABG
metabolic
findings?
Alkalosis with type 1 respiratory failure.
Type 1 respiratory failure. Okay. So you know there is hypoxemia involved. So basic treatment of hypoxemia is oxygen therapy. Fine. Then what else? What other adjoints do you want to do?
You can do if the facility is there, then bedside ultrasound can be done. Both lung ultrasound and abdominal screening can be done.
This is a good patient for doing a lung ultrasound, isn't it? What are you looking for?
One, any pleural effusion, then collapse consolidation.
Okay.
Then any B lines can be checked.
Okay. So blue protocol. You go according to blue protocol. Whether there is pleural sliding present or not. If present, whether there is A, B lines, whether there is any effusions, collapse consolidation. If you see collapse consolidation in ultrasound, how will it look like? What is the sign called?
A star sign, tissue sign, star sign.
Okay, and collapse?
Starry sign.
That is consolidation will have starry sign. What about collapse?
Tissue sign. It will look like the liver parenchyma.
Yes, hepatization of lung features will be there. If there is effusion with collapse?
Then fishtail.
Yes.
Fishtail sign.
Yeah, fishtail sign will be present there. So these things you can do here. If you do a lung ultrasound here, if you are suspecting pulmonary edema, what will you get?
B lines.
Not just B lines. B lines is a non-specific feature. B lines just shows that there is increased intraparenchymal edema. It should be symmetrically present B lines of more than
More than 10 or more than 3 in one
more than
field.
3 in one field or more than
10 in total.
In total, and usually the distance between B lines will be more than 7 millimeters. But that's we can take out. But bilaterally symmetrical B line should be there. In LRTA, if at all unilateral we are looking at, we won't get a bilaterally symmetrical picture. Then you can rule out pulmonary edema with that. Fine. So bedside echo, bedside ultrasound, we can eyeball the LV and see whether LV is contracting properly or not. Any acute thromboembolic, cardioembolic situation is there. Another thing,
ECG.
ECG, echo itself, you can look for pericardial effusions, isn't it? Pericardial effusions. And ECG to rule out any acute thromboembolism, of course, and arrhythmias. The patient is having a heart rate of 122. Still not in arrhythmia range 150, but 122 being tachycardia. You can look into any new onset paroxysmal AF if it is present. Those things you can rule out. Okay, then what else? Now coming to end of this thing, right? Can you take X-ray in this patient?
X-ray can be taken because she's not pregnant anymore.
That's right now. If the patient is pregnant, can you take X-ray?
In the first trimester, it's contraindicated.
Anytime you can take
Then,
if the pros are more.
Yes. The
risk
thing
versus
is,
benefit.
if in this condition we are dealing with a significantly difficult condition which is threatening mother's health. She is having type 1 failure, hypoxia, impending cardiac failure. In this condition, to diagnose its accuracy, we can do one chest X-ray. One chest X-ray per trimester is allowed. Ideally, try our level best not to do it, but it's not contraindicated when mother's life is at stake. Okay, so we can take one, we can provide a lining for the stomach, but we can take one X-ray if needed, Okay, fine. Coming to secondary survey. What are the important history you need to ask her? She is in second trimester, right? Second trimester. How many months? 6 months.
6 months.
Good time. What are the other histories you need to ask about this pregnancy?
We'll have to rule out eclampsia, pre-eclampsia,
Yes,
gestational
hypertension. Pregnancy-induced hypertension you need to rule out because this can very well be a pre-eclampsia crisis, isn't it? Yes. So, pregnancy-induced hypertension, pregnancy, diabetic, this thing also, gestational diabetes also you need to rule out. What else?
She was also found to have hypothyroidism in her pregnancy.
Yes.
So this could have again been because of increased demand for metabolism. Like metabolism increases in pregnancy.
Yes.
So if her body has inadequate thyroid production, then she can go into
cardiac failure. She can go into cardiac failure. Good. These things we need to know. So a history of the pregnancy itself is very important here because those gynecological complications also we need to consider along with surgical and medical. Okay, what are the medical? Now coming to history part, medication. Is she on any other medications?
She is on Thyronorm, 25 microgram. All of that was started during this pregnancy, and then she was also diagnosed to have gestational diabetes. So she was initially on OHA. What OHA we have no idea on. And along with this, she was on insulin, short acting 808 international units she used to take. Okay.
Now coming to sample history part. We can go ahead and get the history. So initial presentation was acute abdomen, right? Acute abdomen. What are the salient points for this patient you will ask?
When if she has any excessive vomiting, bleeding PV, then
any trauma, fall.
Fall.
Then
Then visual disturbances, headache, syncope.
Yes, preeclampsia features can be asked about. Headache, visual disturbance showing raised ICT, chest heaviness, palpitation, sweating, secondary to cardiac emergencies, right hypochondriac pain,
Pain,
isn't it?
hepatitis, jaundice,
Then decreased,
HELP syndrome,
decreased urine output, decreased
bowel and
urine
bladder
output.
movements.
Yeah, urine output important for suspecting renal failure.
Preeclampsia.
Okay, then
Reduce fetal movement perception.
yes, that's important. Now, acute abdomen can be due to gynecological emergencies alone. Like it can be second trimester, 6 months, not clearly, but it can due to placental rupture,
Abrasion.
abruptio placenta can be there, placenta previa, if at all there, it can cause bleeding. Those histories we need to get. We need to get the previous scans also for the baby. It can be due to abortion that is happening also, isn't it? So those histories we need to get. We already know patient had multiple pregnancies in the past with one abortion and two ectopics, right?
Autoimmune has to be.
Yeah, so autoimmune history we have to think. It can be very well be acute exacerbation of a autoimmune condition or vasculitis, isn't it? Those things we need to. Those history here is very important. Both gynecological as well as medical history we need to get. Then coming to examination. This is a patient whose breathing is compromised, on oxygen. You are checked, you are put on oxygen. Right now, with this history, you can go back and recheck the primary survey. She is still having 88, 90% saturation only. Severely tachypneic, respiratory rate is around 40. How will you plan to proceed?
High flow nasal, HFNC.
Yeah, you can plan for HFNC if you are not suspecting pulmonary edema. If you are suspecting LRTI, so history of fever is there, you can suspect LRTI, but here it's very acute onset and think that patient is having pulmonary edema features with effusion, collapse consolidation with the increased B lines bilaterally. With the ongoing 90-60 BP and heart rate of 122, you are suspecting patient to have acute cardiac event causing pulmonary edema. How will you proceed?
In that case, a trial of BiPAP can be given, sir.
Yes, trial of BiPAP you can give. What are the parameters in BiPAP will you concentrate on? What level of BiPAP support do you want to give to the patient?
It will be PEEP, expiratory pressure will be our major focus.
Okay.
Some amount of inspiratory pressure, like up to 10 to 12, can be maintained. You don't want to increase it too much because, again, risk of barotrauma will be there. But here in pulmonary edema, the pathology lies in the alveoli because of increased interstitial edema. So we want to keep the alveoli open, which is why that's where the role of PEEP comes into play.
Okay.
So we'll increase the expiratory pressure.
Okay.
So PEEP, yeah.
Yeah. So you have to give a additional PEEP for the patient to clear the alveolar fluid or edema or secretions, whatever it is there. Spontaneous mode, basically spontaneous mode, because patient is already is a young woman taking full breaths. You don't want a timed mode in here. So spontaneous mode with supportive positive pressure, but with increased PEEP is what you are going to give. What is your target saturation?
95 above.
95 above you will
95, yeah.
keep. Okay. That is positive pressure, and then at this moment when you start positive pressure ventilation, what should be your concern?
One is actually she'll be having reduced gastric movement, so she can aspirate in time.
Yes,
Full abdomen.
yes. So patient has acutely presented to hospital. We don't know when was the last meal. This patient already has raised intra-abdominal pressure due to the gravid uterus. Patient, when we give positive pressure airway, it can go to stomach itself and can cause vomiting and aspiration. So that is a very valid thing you need to keep in mind. And if at all patient vomits, there is a high risk of aspiration since she is on BiPAP. Second thing, she is already having a restrictive condition because of the gravid uterus, and your BiPAP may not be good enough for improving the airway. At this point, you need to get need to inform the bystanders about a possibility of intubation and discuss about the risk and benefit for the patient. is, if we are thinking about intubating this patient, what are the points you will keep in mind or you will look at the patient?
Sir, pregnancy itself is a difficult intubation state. So the difficulties start right from oral cavity airway, and patient can have a swollen edema, a swollen tongue, friable capillaries. So she'll have increased tendency to bleed. So it has to be a very quick, non-traumatic intubation. Then laryngeal edema laryngeal edema will be there.
Yes, laryngeal edema has to be thought about.
Then apart from that, she's a full abdomen. Again, increased risk of aspiration.
Aspiration.
Apnea time is very less.
Okay.
So first of all, patient is hypoxic, so she can desaturate even faster if we are to paralyze her. So quick intubation has to be done.
Due to decreased functional reserve capacity, she will not have the pre-oxygenation time. Even if you give adequate 3 to 4 minutes of pre-oxygenation time, she will not be able to retain that much oxygen to provide you with a apnea time of 20 seconds. So your intubation has to be very quick. Then what?
Then a decreased, prolonged gastric emptying time will be there.
Okay,
Decreased
aspiration.
esophageal tone.
Okay.
So during intubation, we can keep the nasal flow running like 15 liters per minute.
Yes, this is a patient you should think about delayed sequence intubation. More than a rapid sequence, this is an ideal patient for delayed sequence intubation. Initially itself, you think about increasing gastric emptying by giving a prokinetic agent. You can start, even if you are intubating, you can keep high flow nasal airway and do not start bag mask ventilation, continue on BiPAP until you start giving paralytic agent. So delayed sequence intubation can be done. And as you were saying, this patient you can try for a elevated head and intubation technique. Instead of putting the patient on supine mode, you can try to keep the head end at 30 to 40 degrees and try for intubating if you have a experience in that. Okay, fine. So intubation, we have to think about a difficult airway algorithm in this patient. Since all pregnant females, difficult airway algorithm should be kept in mind. LMA should be also be readily available. Okay. Now, airway part is fine. Then coming to systemic examination, we have covered nearly respiratory and CVS, right? What about abdomen?
Abdomen, we have to see where is the thing of umbilicus, uterus, fundus size. You have to see about fundus size, fundus height, then fetal heart sounds, then tenderness.
Any local tenderness we need to think, because pregnant ladies can develop infective surgical causes of acute abdomen. What are the surgical causes you will think about?
Ectopic, appendicitis.
Ectopic is very rare at this time because she is already on 6 months of gestation, right? But yeah, ectopic can be thought about, especially if she haven't done any previous scans. Okay, then appendicitis, good.
Ovarian cysts.
Ovarian cysts, okay, but appendicitis then, yes, acute cholecystitis. Cholecystitis is very good answer. There will be increased cholesterol
production.
This thing, calculus there, which can get infected. So acute cholecystitis can be thought about. Then
fulminant, that's not surgery.
In previous LSCs and scar dehiscence and like
yes, since 3 previous pregnancies are there, we need to think about uterine anatomy, whether any previous cesarean sections has been done. Since abortions are there, it can affect the uterine integrity as such. So any uterine tenderness, whether it is there or not, we need to assess. Along with that, speculum examination should be done to see whether any right now she is pregnant, no? So pelvic inflammatory disease is something that we don't think about at this point of time. But speculum examination can be done to look for any bleeding. But will you do a PV examination?
No.
Yeah.
Not unless
so if it is placenta previa, we may not know, or if at all we know, we should avoid doing a pervaginal examination, because if placenta previa is there and os is opened, we may be worsening the condition. But uterine tenderness is very important, because if uterine tenderness is there, we are looking at a placental abruptio placentia, isn't it? Yes. Similarly, we can look for any contusions for trauma or abuse also. Need to look into that. What else?
Then any peritoneal bleeding can also present as that Gray Cullen's sign.
Yes, so we can look into Gray Cullen sign if patient's skin color allows it. And this patient is already on short-acting insulin, 8 units TAD she is taking, she is having gestational diabetes. What if she has missed her insulins?
DKA.
Yes, there is a possibility of DKA. DKA can present with tachypnea,
Abdominal pain,
can present with
tachycardia.
cardiac involvement of cardiac, and due to the
Breathing
increased volume load, she can go into cardiac failure too, right? So DKA is a possibility over here, but what is unlikely is we didn't get any acidosis. Bicarb is normal, so we don't have to think about that, but GRBS should be taken just to make sure it's not DKA that we are dealing with. Then, anything else?
HELP syndrome.
So HELP syndrome is possibility, but second trimester is too early for it, but HELP syndrome has to be kept in mind. So what will you check for?
Elevated liver enzymes, low platelets, hemolysis,
Yes.
drop in hemoglobin.
So coming what and the blood investigations do you want to send?
Your DIC panel.
Yes, DIC panel will be good to be sent here, especially if you are suspecting abruptio placenta and placenta previa causing bleeding, because you are losing whole blood. So even if you want to transfuse, it's better to arrange. What type of blood will you arrange and keep?
Whole blood. PRP.
Whole blood won't be available in any of the
PRBC.
hospitals currently.
For DIC, it will be FFP and cryoprecipitate.
FFP, cryo, PRBCs, but it's a pregnant female. What will you arrange?
Irradiated.
Blood.
Unmatched cross-match.
You have to, grouping, cross-matching, everything is there, but you have to think about
RH positivity.
Yes, RH factor has to be kept in mind. So if you are going to transfuse the patient with a sudden blood loss, if you see that hemoglobin is dropped or you are saying significant hemolysis is there, and hemolysis is causing the cardiac part, 90-60 BP with tachycardia and breathing difficulty, if you think it's anemia that is causing it, you need to transfuse. And if you are transfusing, you need to arrange RH negative. Given 3 previous pregnancies were there and the mother would have already been sensitized to it, but when you are arranging first time, it's always better to give a RH negative blood product. Then, this case you started with something called as, this is a precious pregnancy. Why did you call this as a precious pregnancy?
If you have recurrent abortions and she's never had a baby before, then this pregnancy becomes a precious pregnancy to the mother.
Yeah, but did she get pregnant by natural means or?
No, ovulation induction, so they were really desperate.
Yes.
Yearning
So
for the baby.
this pregnancy was induced by ovulation, medically. So is there any other clinical condition? A pregnant lady who was
Ovulation hyperstimulation.
ovarian hyperstimulation syndrome. So that is a very good differential diagnosis for a pregnant lady presenting like this. Patient will have anasarca. Usually it's anasarca, not mild edema. It's pure full-blown anasarca. Abdominal, diffuse abdominal pain will be there. Severe breathing difficulty will be there. And you will have serositis. You will have pleural effusion, you will have ascitic fluid, and you can even have pericardial effusion. So in this kind of patient, when they come, ECG, you have to look for low voltage complexes. Most probably will have because of the pregnancy edema, but chest leads, if they show low voltage complexes, you need to do a bedside echo for pericardial effusion also. Similarly, this much serositis is secondary to low albumin. Ovarian hyperstimulation syndrome causes protein loss, severe protein loss. So that can cause severe hypoalbuminemia, which causes diffusion of fluid into the extravascular space. That itself can cause the patient to go into cardiac failure. The treatment of ovarian hyperstimulation syndrome is albumin supplementation, Lasix to take away the extra fluid in the body, and positive pressure ventilation. But here it will be tricky because the patient is pregnant. If you take this as a pregnant case, it is going to be very tricky and you will require a neonatal support for this patient. So any kind of pregnant lady is coming after 20 or 22 weeks of gestation, you should involve your neonatal team also when the patient presents to your department, because neonatal ICU support will be critical if we decide to terminate this patient. Similarly, gynecological assistance should be required if at all the patient requires emergency termination. Fine. So ovarian hyperstimulation should be kept in mind. It's not very common, but since a history of ovulation induction is there, we should keep in mind. Okay, now if at all this patient, after coming to emergency department, you started oxygen, you put the patient on BiPAP, she failed the BiPAP trial and you intubated, and while intubation patient went into cardiac arrest, what will you do?
Then we'll initiate the CPR just as we do it according to the ACLS guidelines.
What is the position of the patient?
Left lateral again.
Yes, so position should be kept minimum 10 to 20 degrees to the left lateral. Okay.
Or supine with one person manually displacing the
Uterus
to left side.
Left side, good.
So with this, we'll start the CPR. The dosages and the whole code will be just in sync with the adult ACLS thing.
Fine.
The other thing that we'll be talking is the perimortem cesarean section, wherein in 5 minutes of CPR, if the patient does not revive, then we will go ahead with the cesarean section on table. And this is done in order to save.
Are we doing a cesarean section?
No, just cutting off and bringing the fetus out.
No, yeah, of course, but it's not cesarean section. Cesarean section is a
not the lower segment incision. Will put an upper.
we do a vertical
vertical
incision, cutting through all abdominal layers and the muscles and opening the uterus vertically. We are not going for a cesarean section. This is vertical incisions we are doing, and we will be planning to take the baby out. This is one of the reasons why any pregnant lady presenting to emergency department in a critical condition, neonatal and gynec teams should be kept on standby, because it's always better to have additional hands when you do, if at all you have to do a perimortem cesarean, when you can concentrate on the cardiac arrest and the other teams are there to help you out with perimortem cesarean. So 5 minutes, that is 2 cardiac cycles, right? 2 minutes reassessment, 2 minutes reassessment, you are not getting perimortem. Fine. So why do you have to do this?
So one is to relieve the pressure on the mother, because of, there are 2 main reasons. One, again, the gravid uterus, despite the placement, it can still compress over the IVCs, which can affect the cardiac output. And the second thing is because hyperdynamic state, 30% of the mother's blood goes to the fetus.
Yeah, a significant portion of cardiac output is diverted to the placenta for the well-being of child. So that delays or decreases our resuscitation efforts. So it's better to, if the fetus is viable, that is more than 20 weeks, it's better to do a perimortem cesarean, take the baby out and give proper resuscitation to the baby by a neonatal team having neonatal resuscitation protocol, and do adult resuscitation for the mother rather than keeping the baby inside and doing a partial resuscitation. Fine. Anything else?
Post resuscitation, we can also think about ECMO in this kind of patients.
Yes, good. Yes, if we think about the current guidelines and all, this is a very good patient for a ECMO trial, because there is no organ failures. Looks very clear-cut case of respiratory failure, hypoxia, type 1 respiratory failure secondary to LRTI. If we put the patient on ECMO, the patient should improve quite nicely. So yes, current guidelines, ECMO should be kept in mind for this patient. Then, okay. Any other things that since we done with our imaginary case scenario, let's come back to reality, and this patient postpartum day 5 presenting with tachypnea, bilateral LRTA is there, abdominal pain is still there. You told surgical site is clean. Anything else you want to do?
Surgical post-op, again patient can have atelectasis. That's a
Post-extubation atelectasis can be there. As you told, during intubation patient could have aspirated and developed aspiration pneumonia. That and all true, but it's post-op day 5. Surgical site is clean. Anything else you want to rule out? It's a post-op case.
Retained conception.
You need to check, you need to do a minimal ultrasound abdomen to look for any
Retained
collections. You told there is uterine rupture. What is the status of uterus right now? Is there any ongoing bleeding there? Is there any abscess or collections present there? The infection to the lung can very well be a seeding from intra-abdomen side, right? Fine. How will you treat now?
Again, bedside ultrasound has to be done to rule out any collections, any free fluid in the abdomen. Then same like sepsis protocol. Early IV antibiotics, collecting the blood culture, checking the serum lactate levels.
Okay.
Then IV, then fluids.
Okay.
Then yeah, that's it. IV.
What are the antibiotics will you give to this patient?
One will be covering the gram negative
Yes.
and anaerobic.
Okay.
Majorly.
So, since aspiration, we have to keep in mind anaerobic coverage, and since we are suspecting a source from the abdomen, also a gram negative. Pan coverage, but some antibiotic that will cover gram negative also. Fine. How is the patient now?
Patient is improving, sir. Off oxygen and chest physio was started. Incentive spirometer was also provided to the patient. So clinically, from the time she had presented to the hospital, she is gradually improving.
Okay. What is the possibility of a pulmonary embolism in this patient?
The only thing that it is a prothrombotic state, so
Yes.
pregnancy. So with recurrent history of abortions and also in the past, any factor C, factor S deficiency,
Yes.
apnea,
Vasculitis
lead
conditions you have to think
irritations,
about.
so that
Will
could
you
have
send? What will you send to diagnose pulmonary embolism?
CTP only has to be done, sir, because D-dimer will be bound to be elevated.
Yes, there is no point in doing D-dimer in this case. It is going to be positive in view of sepsis and in view of pregnancy. So, wasting time with D-dimer is not at all going to help you. Do a bedside echo. Look for acute RV dilation, because since patient is having significant tachycardia, desaturation, 84% in room air, it should be a good enough pulmonary embolism to cause that. Subsegmental pulmonary embolisms usually will not cause this much of hypoxia. So a bedside echo is a good answer, but after that, it's better to go with CTPA. Fine. That's it, right? Okay. Thank you.
Thank you.